시청자 여러분 안녕하세요.
Greetings, ladies and gentlemen. This is Prosthodontics on Friday Night Live, which addresses different steps of prosthodontic treatment and its side effects. We have focused on full denture as part of Back to the Basics series in 2023, and we have studied long and hard. Today, I'd like to summarize what we've discussed thus far about full denture and have a discussion on major points. I've invited special guests because this is the final lecture in 2023. These guests have been with us since the start of the full denture topic. Professor Choi-Tae-gyun of CANLI University and Professor Emeritus Chung Moon-gyu of Yonsei University are here with us today. Thank you for coming despite your busy schedule. You've been with us since the start of the topic full denture, and thanks to your participation, we've received avid responses. There were 17 lectures in total, and there were 1,524 chats and 579 questions raised. I would like to express my gratitude to the two professors here. I would like to express my gratitude to those who have raised questions and comments once again. As I prepared the debate today, I looked at the chat and the comments raised thus far, and I've chosen one that stood out and would like to introduce it today. I think it was towards the beginning, and ID Kyonu raised this question. When fabricating full denture, in the beginning, I thought taking impression was the hardest part, but then I've realized that taking interarch relation was harder. After that, I came to think that occlusal adjustment was harder, but with time, I've realized that patient management was the hardest part. I'm sure this comment resonates with many. Could you provide your opinions on this? By patient management, at which time point specifically, I think there can be differences. Patient management is going to be managed by myself. Taking impression is going to be addressed by Professor Choi-Tae-gyun, interarch relations by Professor Chung Moon-gyu. In my opinion, we can think of this question in wide and narrow sense. And I've looked at it from a wider perspective. I think we need to do a good job maintaining patient from the moment the patient steps in to the point the patient adapts to it. What's your opinion on this, Professor Chung? Patient management is important. I think the first impression is most important. I think success and failure is determined at the first visit. You need to listen in on the patient. You need to understand the patient's characteristic, the situation the patient is in. You need to listen in with a smile rather than a frown. Today, we have this debate topic and two famous professors with us, and I think that's why we are receiving heated response in live chat. Let's take a brief look. Bellotti. I look forward to today's lectures provided by the three professors. La La Land, Professor Choi-no, Choi-Tae-gyun, Chung Moon-gyu. I'm honored to see you all three in one setting. Jai, I look forward to a great lecture today. Olaf, the professors here today are wonderful. I believe the professors sitting next to me are wonderful. Pona, I look forward to a great lecture today. Yang Punch. Professor Choi-Tae-gyun and Professor Chung Moon-gyu, it's great that we can share the start and finish of the topic of full denture together. Caraberos, I'm so sad that it's the last lecture today. Yang Punch has mentioned that it's great that Professor Choi-Tae-gyun and Professor Chung Moon-gyu can share the start and finish of full denture. And I would like to ask the program director to gift a coupon to this person on Monday.
커피 쿠폰 하나 보내드리주시면 좋을 것 같은데요. 괜찮으시죠?
Sounds good. Thank you everyone for leaving words of encouragement.
대단히 감사의 말씀을 드리겠습니다.
As you've seen, if you can leave words of encouragement and questions, you can communicate with us real time. If you raise your questions, you can have them answered real time, and through lucky draw, you'll be able to win Starbucks coffee coupons. If you leave great questions about full denture, 3 people will be selected as best question raisers. Professor Choi Tae-kyun, Professor Jung Moon-gyu, and I'll choose 1 person each, and those selected will receive chicken coupons. I look forward to your keen interest and participation. Now let us begin the debate on full denture as part of Prosthodontics on Friday. Professor Choi Tae-kyun, could you start? Greetings, I'm Professor Choi Tae-kyun. Today I'd like to primarily talk about preliminary impression. Preliminary impression is very important. Final impression is determined about 80-90% by preliminary impression. So you need to do a good job here to get a good final impression. I like this saying, a journey of 1,000 miles starts with 1 step. So up to final impression, you need to take a preliminary impression and do border molding. You have to go through a series of process. If you have done wrong job in preliminary impression, everything can go wrong. I would like to provide a brief explanation about how to do a good job. It may vary from person to person, but let me give you my tip. Choosing the right tray is impression, and when taking alginate impression, you need to look at the flow of the alginate. And the tray with impression material should be positioned intraorally appropriately. You should not do everything all at once. Do not do final seating at once. Do it in 2 stages. That is my recommendation. As for choosing tray, the distance between the flange of the tray and vestibule should be about 5 to 6 millimeters. Regarding mixing of impression material, there is always a defined water to powder ratio recommended by manufacturer, but adding 5% less water is more advisable. In the case of impression material flow, it's better to slightly adjust the water to powder ratio, reducing it by about 5% to enhance the flow properties. So, seating intraorally. You need to seat it about 70 to 80% rather than 100%. So this is phase 1. The air bubbles in the margin are removed and border molding is done. In phase 2, 20 to 30% is not properly seated, so you do the rest. You do border molding, then hold it. By doing this kind of impression can be done. If you do a good job here, preliminary impression with a margin similar to that of final impression can be achieved.
예비 인상이자라면 최종 인상의 변형 형태를 충분히 짐작해 볼 수 있기 때문에 좋지 않아 생각되어지고요.
This was mentioned earlier, but final impression is determined 80-90% by preliminary impression. We need to make sure we do preliminary impression nicely. If you do not do that, and if you just try to make more effort starting from border molding, then things can become difficult. As for marginal formation in the upper jaw, typically, marginal areas are border molded using modeling compound. Posterior palatal seal should be reflected appropriately, and that is the way you take impression for the upper. In the case of lower, you can do border molding for the marginal area. Some people find this hard, so let me give you a easier way to do this. This is the way I do it. Modeling compound is softened, just like loading alginate into the mix. You soften it. Yes, heat processing is necessary to maintain it in a consistent temperature. When you do seating, the overall border can be gained. You soften the inner surface and have the patient move his or her tongue, and then soften the outer surface. By having the patient do tongue movement, border molding can be gained. Professor Che, can I ask you a question? Can we go back to modeling compound? When you take impression using modeling compound, pressure can be applied, pressure impression can be done. Yes, I agree. After that, you can remove the undercut upon final impression. With the undercut removed, wash process can be done. Then, impression can be done without pressure. Please carry on. This is GOE paste. You mix it and load it. In the case of lower, if you have the patient to move tongue, then there will be no tray exposure. GOE paste has excellent flow, but this kind of impression can result. I do not do pressure impression for full denture cases. In the case of partial denture, at times I do use it. So that is my preference. Excuse me. Regarding the marginal area, impression can be gained like this. You can gain modeling compound with alginate impression. You can do border molding and do final impression. By repeating the process, you can get these kind of impressions. There's no areas with exposure. I think these are fine. Last, it's hard to define appropriate final impression. Assuming that what I've done is appropriate, let me give you my opinion on what can be considered as acceptable. From a nicely done model, we need to get a good individual tray. If a custom tray is well crafted, ensuring that the impression material covers at least the area of the tray, it should provide enough detail to create a denture that can be used comfortably and without significant issues. Now, considering this, even if you encounter failures in border molding, if time is limited, it's always possible to at least get an impression covering the extent of individual tray, so I suggest starting from this point and see how it goes. This is the end of my lecture. Thank you. Professor Che, thank you for summarizing about impression within a short period of time. Next, Professor Chung Mung-gyu is going to talk about inter-arch relations. These were the questions raised. First, 라리기. If there is significant discrepancy between CR and CO, I believe this was the result of extremely low vertical dimension. We need to provide freedom of centric. If it is excessive in the case of lower, I tend to give more freedom. If it is too extensive, as for the lower, I make it edentulous. This is to provide more freedom. As for the second question, I use swallowing technique. So if the vertical dimension is high, the patient can feel more pain. As a person ages, vertical dimension tends to be reduced. We look at the teeth and periodontal tissues, but in the end, a treating patient is about dealing with persons. So mutual respect and mutual confidence is very important. If you build a good rapport with your patient, then the treatment will go smoothly. If the rapport is not formed properly, perhaps you should delay treatment. This is referred to as forming rapport. Forming good relation with your patient. What is most important is not about saying what you have to say, but listening to the patient. You need to listen to the patient's family relations and who is going to pay for treatment and whether the patient is engaged in any social activities. You need to give an impression that you care about this patient. By leaving such impression, good relations can be formed. As for interarch relations, record base is the biggest issue. This is also referred to as trial base. If you overlook it, the error from the base can be more significant from error from the record. When you put in record base, there needs to be very little or no movement. You need to do a proper job using record base to reduce many errors. And you need to have the patient relax. To get interarch relation, you need to retreat the mandible, but even if you push with your hands, that's not possible. The hand shown on the image is my hand. So I use my hands to explain to my patient how to relax. And the mandible should be in such condition as well. You need to explain the difference between bite and close. What we want is not to bite, but close. If relaxing can be done nicely, this will not be a problem. Rather than using alcohol lamp, I prefer water base. Softening can be done left and right the same. The lower is softened first, and you have the patient swallow and do tongue movement. The neutral zone can be formed, and shape can be gained. Then I move on to occlusal plane in the lower. The lower is more unfavorable. You need to begin by establishing the occlusal area of the mandible by referencing areas such as corner of the mouth, lower lip, or retromolar pad. After cooling it with ice water, apply a layer of Vaseline, then you can proceed to adjust the maxilla. As for the upper, with the vertical dimension slightly high, you can put it in the oral cavity after softening it. You can have the patient do swallowing movements, or you can have the patient and the caregiver go out for a couple of minutes, then the patient will do pronunciations or swallowing and find the vertical centric. So, Professor Chung, you use swallowing technique threshold to get vertical dimension. Professor Che, what kind of method do you use? I do not rely on the patient. So you take a different approach from Professor Chung, who has the patient do it themselves. I choose the occlusal plane randomly, and when aligning artificial teeth, I do lower first. When you know the length of the anterior zone, you determine the occlusal plane from the lower. When you do upper, you need to consider lip support and aesthetics. As for the lower, The wax rim should not be in contact with the posterior zone. There should only be in contact in the anterior zone. You have the patient pronounce words. I look at whether the closed speaking space is 1 millimeter at least. You have the patient pronounce S or TS pronunciations. Because there's no contact in the posterior area and contact in the anterior zone, you can observe it. You utilize that to determine vertical dimension. You have the patient bite lightly and you guide the CR. So Professor Che, you focus on aesthetics and pronunciation. I think all three of us are different. I guide the breast position. The freeway space needs to be 2 to 3 millimeters. That needs to be removed. And occlusal dimension is determined. Professor Chong, you focus on the patient. You provide explanation to the patient and utilize swallowing threshold. Professor Che, you focus on aesthetics and pronunciation, and I utilize position at rest. So you need to choose the right method for yourself. You need to choose the method that feels right to you. As for pronunciation, I just ask about the address. I ask, where do you live? And I look at whether disclusion occurs. If you ask the patient to pronounce difficult words, it's impossible. Professor Chong, your school is located in Seodaemun area, so when you have the patient pronounce their address, there's the S pronunciation. Another point I like to talk about. If you look at the alignment from the lab, the teeth from the manufacturers are used. The patient cannot use this. The patient has been using this quite a while. Cuspal inclination is quite low. If you look at the next image, no matter how intricate and precise you do on the articulator, there's difference between oral cavity and articulator. You need to look at specifics intraorally once again. In the case of partial freehand, occlusion does not occur in the posterior area in most cases. So if you use amalgam material in the posterior area, with a certain period of use, you can see centric stop or travel path of the opposing cusp formed, as shown. The cuspal inclination needs to be this much low for the patient to use the denture nicely. This is the upper. All patients are different, so we need to understand each and every patient. Natural teeth and periodontal tissues are given by God, and prosthesis is made by human. I believe that comparing the two is impossible. We need to be humble and do our best to treat our patients. This is the end of my lecture. Professor Chung Moon-yu, thank you for explaining nicely about inter-arch relations. You have expanded our horizon. Thank you. Last but not least, it's about patient management, and I'll proceed about patient management portion. As mentioned earlier, we need to provide a thorough care from the initial visit to the point where the patient adjusts nicely to the provided denture. For patients using denture for the first time, they have quite high expectations. You need to help them really understand the reality of denture. We need to lower the expectations. On textbook, patient personalities are divided into 4 categories. And I'm sure you've all learned of this. From private practitioner's perspective, a reasonable patient is the easiest patient to treat. Even if the patient is critical, if you provide thorough explanation and if the patient understands the logic of it, then patient compliance can be excellent. However, if the patient is skeptical, then it can be quite difficult to treat and manage. And you need to refer the patient to university hospital. I think that is a way to treat this kind of patient. As Professor Jung has mentioned, it is very important to communicate with your patient and form trust relationship. I want to talk about this movie. It's been some time since it was released. It's called The Way Home. The grandma and her grandson talks about chicken. The grandson explains about the fried chicken from KFC, but the grandma comes up with this traditional Korean steamed chicken, so the grandson refuses to eat this and runs outside. In the same context, we need to build trust, or else treatment can be bound for failure. For instance, the surgery may have gone well, but the patient may have passed away. In the same sense, if we provide denture and if the patient cannot use it, it's the same context. If there's no trust, then it would be the same as angry denture going in, and angry denture is bound for failure. We need to manage the psychological aspect of patient with different personalities. This is the clinical side. We need to also make sure the patient uses the denture well. We need to look at the denture fit and look at PIP and fit checker. We need to make sure that the denture is maintained and stability is preserved. In full denture, occlusion is very important as well. Occlusal adjustment. We can do selective grinding to provide bilateral balanced occlusion. We can provide different kind of occlusion, but academically, bilateral balanced occlusion is considered the best, so we need to provide this to get good results. Regarding adjustment and adaptation, let's take a look at some of the questions raised. Awesome, Jaro 214, and other people have asked about cheek biting and tongue biting. When there's cheek or tongue biting, as we all know, we need to secure horizontal overlap on the buccal side, and if the cusp inclination is steep, we need to make it more shallow. When there's tongue biting, we need to provide similar solution on the lingual side. Professor Che, what do you do when there's cheek biting? If there's cheek biting where the artificial teeth are, or when there is cheek biting in the most distal area, if there's no space between retromolar pad and habular notch, there can be cheek biting as well. In the case of the posterior area, you can just form space. In extreme cases, so you may have to cut a bit of retromolar pad. If there's cheek biting on the artificial teeth side, at times when there's no overjet, this problem can occur. If you look at textbook, if there's lack of vertical dimension, there can be cheek biting as well, and I agree to that point. If vertical dimension is low, and if this leads to cheek biting or tongue biting, what do you do to address it? You need to increase VD. You need to do occlusal check. You need to mount it on the articulator and increase VD. You need to cut out artificial teeth and do alignment fresh to increase VD. So you replace the artificial teeth. Professor Chung, As you have mentioned, you need to form occlusal plane fresh, and you need to consider this as well. With age, muscle and our skin lose elasticity, so this kind of tendency increases. With age, your muscles may sag and there can be cheek biting. Because the patient's reflex may be slower, these problems may arise. As for me, when the patient receives denture for the first time, I tell the patient to eat slowly. If they chew rapidly, then there can be cheek or tongue biting, so I tell the patient to chew slowly. Once our muscles are trained and our reflex system learns of this new environment, there needs to be memory pattern installed to your head. Also, the amount of food should be less than normal amount for a certain period. Thank you for your input. Many questions were also raised about relining as well. Do you use indirect or direct method? And the materials used. When we do relining, there's the direct method and indirect method. As for indirect method, there's the static method and the functional method. You can use a verticulator, and at times you can use direct resin, or you can also do curing. The materials used. There's different options available as well. There's temporary reliner, Moloplast B. Semi-permanent materials are available as well. There's also hard resin for relining. Professor Chong, do you use a direct method or do you use indirect method for relining? Indirect method. Considering various factors such as bonding, I primarily use conditioner. I do dynamic impression. There is a functional impression method as well. But the patient needs to come by frequently, and it takes time for the lab to provide with the prosthesis. I hope a lab can speed things up, but these days it takes longer. I do direct method. I choose the direct method inevitably because the days the patient goes by without the denture becomes extended or else. The best way is to send it to the lab and cure it, but the patient needs to use it immediately. So almost 100% of the time I use direct method. I believe that the patient should have 2 dentures. The patient can take the spare denture when they go on travels. Just like we have spare shoes, the patient should have spare dentures. When the patient uses one denture for some time and then moves on to the next denture, at first it may feel awkward. But you can just do slight adjustment. You can do direct reline. Understood? So this is similar to what we've thus mentioned. Maintenance is very important, and patient education is very important as well. The importance of education is quite crucial to success of full denture. So we need to pay attention in providing thorough education to the patient, more so than education provided by hygienists or other team members. I think it is most effective when the dentist, he or she, provides such education. For implant patients, the kind of patient response you get is different from when the dentist provides explanation and when the hygienist provides explanation. I think it's very important that the dentist provides explanation directly, and this message needs to be reinforced by hygienist. We need to understand the patient personality and manage the patient from start to finish. At times, elderly patients may have difficulty understanding, so we need to provide appropriate education to the caregivers as well, so that the patient can maintain full denture nicely. So I like to close my lecture on patient management on this note.
저의 환자 관리에 대한 내용을 마쳤습니다.
Professor Cha, do you have anything? Professor Chu, do you have anything to add? No. In terms of patient management, I think patient personality plays a big part. People who are really neat manage their dentures nicely, whereas others don't really care as much. I think personality plays a big role. Perhaps we can change that with education a little bit. It doesn't really change in my perspective because the patient has maintained their habits for over 60, 70 years. Based on the 3 topics we have discussed about full denture, I believe today's prosthodontics on Friday is especially more meaningful because the 2 professors have graced us with their presence. Because they're so famous, I believe we have received a lot of questions. Through Q&A session, we will address your questions. I'm sure there are many questions, and we're going to only address the questions that are in line with today's topic. This is because of time constraint. I hope you understand. Let's look at the real-time chat screen in dental site. As mentioned earlier, please understand that we may not be able to answer all the questions. First, Uja, which is the best way to measure VD? I look forward to your valuable input. This was already addressed earlier by the 3 of us, so we'll skip. I think this question is about artificial teeth alignment and full denture. In upper full denture, if the buccal alveolar ridge is reduced and if the teeth alignment needs to be done towards the buccal side of alveolar ridge, upon mastication, denture dislodgement occurs frequently. What should I do in this case? I think this is a case of out of ridge. Professor Che, I give normal occlusion regardless of it, even in extreme cases, but it can be unfavorable. It may be unfavorable. If you do crossbite in the posterior area, it can invade the tongue space, so it can be more unfavorable. So I align starting from the lower and align the upper accordingly. There were a number of cases where it was out of ridge, but there were no major problems. Professor Chung? I think it depends on the level of discrepancy. In extreme cases, I align it in crossbite form. Understood? Square. When obtaining CR bite, the patient protrudes the wax bite. How can I solve this problem, as opposed to what was instructed? In my case, I make the wax rim contactless on the anterior zone. As mentioned earlier, this is about close and bite. The patient protrudes it habitually. You need to provide thorough explanation. This is because the patient bites. If the patient closes rather than bites, then the problem will be resolved. And if you adjust the contact in the anterior zone, then it will be better. The patient will protrude less. Another question from Square. the patient may complain of pain in oblique ridge and mylohyoid ridge. And is there no other way but to reduce the border? The lower denture, which used to fit perfectly, seems to lose retention significantly after adjusting it following the patient's complaint that it hurts. Professor Che, the mylohyoid muscle is attached to mylohyoid ridge, so therefore it should be covered. I think it may have to do with the way that the adjustments are made. As you adjust it after patient complains of pain, perhaps just the length was removed. The lingual border, if it is the same as mylohyoid ridge or shorter, then the patient will feel pain. The mylohyoid ridge should be 3 to 4 millimeters below that. Even if you grind it, the patient can feel sensitivity, and because it's where the rest goes, and for stability, it should be extended further from the mylohyoid ridge. The inner surface instead of the border should be adjusted. Naro, what about using rubber impression rather than alginate impression when taking preliminary impression? Professor Che? There's no need to use rubber impression, which is more pricey. It's more pricey. Also, it's more difficult to take impression with it. So there's no reason not to do it, but in general, if you use regular dye, it might drip. So this is not about taking final impression. I don't think so. Dent 0530, do you take preliminary impression yourself? Yes. Yes. If you have the hygienist to take preliminary impression, then it will be a disaster. You need to do it yourself. You need to check the residual ridge and margin. If you ask a third party to take it, and if only the final impression is taken by the dentist, it will lead to failure. You need to do preliminary impression yourself. Dent 0530, all three of us do preliminary impression ourselves. So I hope in the future you do it yourself as well. To add, in full denture cases, because it's fully dentulous, some dentists just use a mirror and take a look, but you need to do inspection thoroughly. You need to use your hands. You need to see where the border is. In most cases, people just look at it with a mirror and then move on. That's a problem. Some may even have the hygienist to take impression. You need to use your fingers and press upon it and check elasticity, and the thickness of the ridge and median palatine raphe line needs to be checked. You need to assess how much relief needs to be provided. You need to check it with your hands. You need to check the posterior palatal seal area as well. This is quite important, as was emphasized previously. If you think about the concept of suction, it's quite important. Hwa-ung, regarding teeth alignment in the upper posterior area, on one side it's crossbite, on the other side it's normal occlusion. What precautions do I need to take? Teeth alignment seems to be quite hard because of the resorption of alveolar ridge. This is about teeth alignment and occlusion. On one side it's crossbite, the other side it's normal. It may not be easy. Professor Che, do you have experience with it? Clinically, there are many cases where there is difference in the amount of ridge resorption, depending on the timing of tooth extraction and so forth. There are such instances. I've never done a cross occlusion when I was learning. When I was an intern, I attempted crossbite. As Gishi mentioned, If the angle between the upper and lower ridge and occlusal plane is over 80 degrees, then crossbite should be done. I did try that. So the lower will be placed in the upper, and the lower will be placed in the lower. By doing this, there will be a nice fit. However, doing this did not have any significance. These days, rather than taking that approach, I just do normal alignment. The upper ridge is much bigger than lower ridge. Professor Chung, I consider the stability of denture, and I often do crossbite in combination situations. In one side, there can be more resorption than the other. In that case, what kind of things do we need to watch out for? You need to reduce the cuspal inclination significantly, as mentioned earlier. You mean cuspless tooth and semi-anatomic tooth, because this is not normal occlusion. Stability can go down. If there is cusp, you need to reduce it. Understood? Thron 70. Upon border molding, is there a way to fixate the tray in order to prevent movement? Upon border molding, what do you do to prevent movement? If there's blockout and relief because of retrievability of tray, there's no way to stop movement, especially in the lower. Just like doing alginate impression, if you do that, then there will be no movement. Professor Che, you talked about modeling compound. I think you cannot prevent movement completely. If you do as Professor Che has mentioned, then there will be no movement. You need to stabilize it and then move on to the border. It's not because of that, but in the end, you can get this kind of result. What I don't understand is that when you do border molding, if there's wax space, there's no movement. Tray positioning at the final impression is the problem, but during border molding, it's not a problem because it's filled up, because there's wax. So I believe the final part. I think this person removes it and sends it. If there's wax, you can soften it, and if the fit is bad, and if there is movement, if you press upon it, it gets improved. I make my own tray. Just in case, if you do not remove the wax, and in the marginal area, modeling compound can get in the way. So just remove wax in the flange area, and in the palatal area, if it is upper, you keep it. You remove wax upon final impression. Square. Do you provide stop on the tissue? Upon border molding, by providing stop, I think this person is talking about doing border molding without wax. In the case of lower, you provide stop in the buccal shelf. As stipulated in the textbook, if the tray comes in contact with the buccal shelf, it does not move. This is selective pressure impression technique. In the upper, posterior palatal seal serves as stop as well. Shindream, you use a modeling compound for border molding, but the process of removing it takes a lot of time and it's cumbersome. Rather than border molding, can I use wax model after taking impression and set border using tissue conditioner? I don't really understand. Wax model. After taking impression on wax model, using tissue conditioner, border molding is done. I think this person is talking about after teeth alignment and is making adjustments on wax denture. But you cannot do it on the model. After taking impression, is this person talking about wax denture? I think this person is talking about using tissue conditioner on wax denture. But you need to make a new model. Perhaps it can be possible. When I do dynamic impression technique, it's about repairing old denture, but after 24 hours, I pour model. Right after taking impression, because it can change due to elasticity, perhaps because of the weight of plaster, deformation can occur. But after 2 to 3 days, changes can be made during that duration. So after 24 hours, perhaps it can be okay, square. What is your criteria for selecting impression material? Professor Che, you talked about modeling compound for impression. What kind of impression material should you use? It doesn't matter, so long as the flow is good. Materials with good flow. May I add? The flow should be good. I make a lot of holes on the tray. So this is to allow excess amount to come out. When I work with my students and have them hold on it, then it ends up being a pressure impression. I always tell them not to press upon it, but then it ends up like that. I always tell them not to press it and just to hold it, but it always ends up as a pressure impression. Upon final impression, because full setting is required, I always do the process myself. Having a lot of holes in the tray can help in positioning, understood? Because it comes out. Young-Hooni, thank you for the wonderful lecture. Your words inspire me to look back on my practice. My question is regarding the lingual torus in the lower, which is quite significant. Considering the patient's age and medical history, surgical approach is deemed difficult. What should I do in this case? I look forward to your valuable insight. If the size is significant, perhaps you need to do surgery. I think you need to do surgery. 85-year-old patient came to my hospital. At my clinic, there's a fellow dentist who is a maxillofacial surgeon, so in that case, I have the dentist address the problem. In general, various surgical inspections are done before proceeding with surgery. So I am not a oromaxillofacial surgeon. If the torus is significant, you need to process it. You need to refer the patient to university hospital and then proceed with treatment. Choi Winning, I think this is a question to Professor Chung. What is the clear material you used? The material you've used with the water base? The trial base? It is clear resin. Clear resin. So there was nothing on the inner surface. It's just a clear resin and the wax goes on top. That's what I thought. DSKSH1, dementia patient with hearing impairment. Impression can be taken appropriately for the upper, but in the case of lower, because the patient cannot manage tongue movement, Is there a know-how to take appropriate impression for the lower or to set to the lower border? In my case, a preliminary impression is possible, so I do my best in taking preliminary impression. I do have dementia patients at times. I do not do border molding and just proceed with impression taking using just individual tray. It may be rare, but border molding is impossible for dementia patients. If you can do a good job with preliminary impression, individual tray can be gained. If you use individual tray for treatment, you can get appropriate results. I believe appropriate impression can be gained using this. For the lower, preliminary impression is not affected whether the patient has dementia or not. Labial and lingual aspect we can manage even if the patient has dementia, but the patient cannot do tongue movement in this case. So you don't have the patient do tongue movement. You just leave the patient to do whatever. If you don't do tongue movement in the extension area, it can become slightly more. If you do a good job border molding, even with just preliminary impression, you get an idea where the border molding will be. I'm sure the two professors here with me today have such an idea. In complete denture, you make adjustments and provide it to the patient. Square in my case, I tell my patient to look at me and show them what to do. So the dentist will stick his or her tongue out and ask the patient to repeat. At times, while taking impression, we burst into laughter. That is the problem. Yesterday, it took a whole hour to take preliminary impression for a patient who was in 50s. And we asked the patient to stick tongue out, but the patient could not do it. So it took me an hour. At times, there's such patients. Instead of doing what was asked of, the patient lifted the tray with his or her tongue and moved the tongue around it. Dentist 0530, this person is talking about measuring VD using the tip of the nose and chin. I think this person has the patient at rest. It's one of the good ways. You can choose the right method that's right for you. Profile. Curry King, Professor Jung, thank you for your valuable input. So this person is really appreciative of your advice. Can do if the lower protrusion is observed when you fit the record base. Do you align teeth so that the lower looks less protruded and make it so that the upper anteriors cover lower anteriors? I think this person is talking about class 3. This person is talking about class 3. This person is talking about intentionally protruding the upper to cover the lower, to make it normal. So I've done up to edge, but having normal occlusion is difficult. Gothic arch. Awesome. In the lower posterior area, when I try to get retention from the lingual undercut at times, upon impression taking and usage, scars can occur. How can I minimize this? Lingual undercut. I think this person is talking about mylohyoid fossa. In the beginning, I think I have had similar experiences. I believe Osstem is fairly young dentist. When I was younger, I pondered long and hard about this. If you do border molding, it will be overextended, and I spent time adjusting it. If the tongue can move naturally, it's okay, but if that's not possible, you just need to continuously try until you get used to it. Even if you get blamed by the patient along the way, you need to continue to make the effort and try. With time, you'll be able to master it. Lizard, what is the most important precaution or word of advice would you give to a patient with denture? Professor Che? As we all know, there are printouts that we give to the patient. What I want to emphasize here most is that there will inevitably be pain. It's all in the guidelines from the association, but you really need to read between the lines, so you need to make your printouts more loud and clear. I always put the symptoms at the very first. I always say that it's gonna hurt and how to respond to it. Second, I move on to precautions. For instance, not to drink too hot water. In general, these wordings are very vague, so it leaves the patient with an impression that it shouldn't hurt. So I always tell the patient it's gonna hurt eventually. I say to my patient, it's fine if you come back with a frown tomorrow because it's going to hurt real bad. Most patients laugh it off because they don't think it's going to hurt, but the next day, they come back with a frown. I always say that it's fine if you come back with a frown. If it doesn't hurt, that's great. If it hurts, well then, what did I tell you? I always emphasize that it's going to hurt like crazy. Professor Chung, I always have my patients come back the next day of delivery. Second follow-up should be at 3-4 days, third within a week, and then I move on from there. The question circles about what to tell a patient rather than doing checkups. I always tell my patient to come back to recall checkups. With time and continued use, your sofa sinks down, and in the same context, our gingiva change continuously, so I tell my patient to come back regularly. I always tell my patient that it hurts, and just like learning how to ride a bike for the first time, when a new denture goes in, it takes time for the patient to get used to. So in the beginning, the patient should not choose something that is excessively hard. And until the patient gets used to the new denture, the patient needs to be careful. Instead of saying that it might hurt, you need to say it will hurt. Awesome. Upon relining, how do you pre-process the metal plate on the palatal side? Is there a way to minimize the discoloration? Denture with metal base and doing relining on it. What's your opinion? Metal plate and resin do not stick. Gap is bound to occur. Hence, I keep using tissue conditioner and repeatedly remove it. I do this several times and then check the next day to ensure that the tissue conditioner hasn't extended over to the metal. So if you use tissue conditioner, it will be covered by resin. So I think it's a good idea. Doing direct method, it's difficult with that. And from scratch, when we design metal, we can ask so that the resin shows through on the outer side. That can be a good way as well. Anyway, bonding metal with resin is difficult. Previously, we did silly coating, but doing silly coating in private dental clinic is quite tough. There's not a lot of time left. Joey Winning, Professor Chung, could you provide a more detailed explanation about taking inter-arch relations.
환자 이렇게 이제 갔다가
About how you manage the patient. As mentioned earlier, I primarily focus on the lower. I set the occlusal plane in the lower. And for the upper, I use one that is a bit high and soften it and have the patient adjust to it. Goodman, tongue biting and cheek biting. This was addressed earlier. Wait 1 second. JIYEQLL. Although the patient claims that the denture was well taken care of, at times there is calculus on it. What kind of denture cleansing can I provide for my patient? Calculus. When the patient does not use that side, calculus can accumulate. Also, it can depend on the constituent of saliva and the amount of saliva. There's no specific way we need to do polishing and have the patient come by frequently. Horizontal relation. There's still so many questions left. So let's briefly go through what kind of questions we've received. Horizontal relation. Way to register CR. What do you think about replicating the existing denture to utilize it like an individual trait to take impression? Because we need to select the best question, I believe we will not be able to answer these questions. Let's go over the questions first. YouTube nickname. With long-term use of full denture, why do you think occlusion changes to reverse curve of Spee and Wilson? How do you take impression if there's a flabby tissue? This was addressed earlier. So this was thorough reply. Taking first impression is very hard. Slowly, if there is significant discrepancy to the point that there is a less than 70-degree angle of interalveolar ridge line in the posterior upper and lower, should I intentionally make a crossbite when I align teeth? So we did go through all the questions. We need to choose the best question out of all these. Understood? Because of time constraint, we were not able to answer the questions in detail. I apologize for that, Professor Choi Tae-kyun, Professor Chung Moon-gyu. Thank you for providing in-depth answers. Thank you, dear viewers, for raising lots of questions and leaving words of encouragement. I could really sense that you were sad to hear that this was the last prosthodontics on Friday this year. As mentioned, we're going to choose the best question among the questions raised. The winners will receive Gyochon chicken coupons. Professor Che, Professor Chung, could you make your pick? One person each. Professor Che, who would you pick? ID, please, coffee? Thank you for the wonderful lecture. ID, thank you for the wonderful lecture. Thank you for the wonderful lecture. I'll choose ID awesome. There were not that many questions. So I would like to congratulate ID Coffee, please. ID, thank you for the wonderful lecture. And ID awesome. Congratulations. You have been selected as best question raisers, so chicken coupons will be sent on Monday via text. please don't feel too let down for not winning the Best Question Award, despite having raised many questions. We'll have a lucky draw and a total of 10 people will receive Starbucks coffee coupons. Last but not least, Professor Che, Professor Jung, could you give a word of advice to those who are studying up until late with us watching prosthodontics on Friday and studying about full dentures? Professor Che Tae-kyun first. The title is Back to the Basics. It may sound mundane as if I'm reading from a textbook, but I hope you continuously remind yourself of the basics, and with continued effort, I'm sure you'll be able to do a terrific job. Yes, it may be hard, but if you continue on, you'll be able to master this technique. Don't feel too afraid about receiving complaints from the patient. Don't worry about patient claims too much, and if you have the will, why not move forward with what you believe? So it sounds as if you're emphasizing the importance of basics. Professor Chung, I hope you like dentistry as you perform treatment. You need to like what you do. Also, you need to do better than other people. Third, in order to do a great job, you need to watch prosthodontics on Friday. Yes. Last but not least, it's the same with everything else, but we need to do it right. We need to do things right. Liking what you do, doing good at what you do, and doing things right. This is what I want to say. Thank you for the great advice, and thank you for coming here despite your busy schedule. Thank you for the wonderful lectures provided. Today we're going to end off with a different note. We first started airing the program in August 14th, 2020, and over the course of 3.5 years, Prosthodontics on Friday rejoiced in your interest and participation, and now that has come to an end. During the set period, 42 of Korea's best prosthodontic gurus appeared in a total of 69 episodes. We went through a series of topics regarding implant treatment and prosthodontic treatment for full denture, and this has led to fruition of 2 textbooks, one for implant treatment and one for full denture. Personally, I feel really honored to have taken part in this endeavor, and the time we spent together was priceless. Although live program is ending, if you go to Dental's site, you'll be able to watch VOD once again. You can access them always, so please visit Dental. If you want to get a deep dive into prosthodontics, please refer to a textbook under the title Prosthodontics on Friday. I hope the best for all of you in the following year, and I look forward to your continued love and interest in dental. Next year, we will return with more meaningful programs that will be of help to many dentists. I would like to say thank you once again as the chair of Prosthodontics of Friday. And that's it for the lecture provided by myself, Professor Che Tae-kyun, and Professor Chung Min-gyu. Thank you. Hard work. Greetings, ladies and gentlemen. I am Professor Jo In-woo. the chair of prosthodontics on Friday Night Live, starting off fresh today. We aim to address the different steps of dental prosthodontic treatment in an easy way and address the side effects.
좋은 강의 감사합니다.
I'm a dentist from Mongolia and I really enjoy the program. I always look forward to Friday. Let's go! At times it might seem too much, but don't give up and focus on your technique with confidence. I hope a lot of patients benefit from the treatment provided by yourselves. Everyone, best of luck. Thank you. Lots of love to everyone.